Assalamu alaikum. This presentation is on the special features of vocal fold paralysis in children. The pediatric vocal fold paralysis, either unilateral or bilateral, is an important cause for pediatric stridor, feeding difficulties, aspiration, and voice problems. The pediatric and the adult vocal fold palsy differ, not only in the etiology, but also in the presentation, the natural history, and the management strategies. There is a significant higher rates of spontaneous recovery in pediatrics, particularly in the idiopathic and the traumatic groups, those traumas caused by birth injury. And there are also the concomitant anomalies that are quite frequent in the cases of pediatric vocal fold pulses. More than half of the cases would have other congenital anomalies, including things like laryngomalacia, subglottic stenosis, or swallowing dysfunction. How common is pediatric vocal fold palsy? Unilateral vocal fold palsy in pediatric group is expectedly more commonly reported than the bilateral cases. It was estimated that the incidence of bilateral vocal fold palsy in the pediatrics is less than 1 case per million per year. The adult figure for unilateral vocal fold palsy per year is just less than 1 case per 100,000 persons. So this is quite rare to have bilateral vocal fold palsy in a pediatric group. But it remains the second most common congenital laryngeal abnormalities in children, accounting for somewhere between 10 and 20% of all the pediatric laryngeal conditions, comes only second to laryngomalacia. The etiology of vocal fold palsy in the pediatric group varies according to the age of presentation. In the neonates, those less than 6 months of age, the important causes are congenital anomalies and birth trauma. Congenital anomalies like hydrocephalus, meningoceles, meningomyoceles, encephaloceles, and Arnold-Chiari malformation. Birth trauma is not uncommon due to the anatomy of the recurrent laryngeal nerve that makes it more vulnerable to injury during birth. But other iatrogenic causes include things like endotracheal intubation in the neonates or surgical correction of thoracic or cardiovascular anomalies such as repair of tracheoesophageal fistulas, for example. But the cause for the pediatric vocal fold palsy in children above the age of 6 months is a bit different. The major cause would be idiopathic. This accounts for up to 42% of the pediatric cases. The cause would remain unknown. Some congenital cases would still present in children above the age of 6 months, like the Arnold-Chiari malformation, for example, or some genetic syndromes like the Charcot-Marie tooth or the trisomy 21. But there are other causes, like infection, for example. Antibiotics and vaccination had reduced the infection causes dramatically. It used to be much higher. Causes like whooping cough or encephalitis or polio or diphtheria, rabies, tetanus, syphilis, and even botulism were at one point much higher than in today. There are also some neurological cases like Guillain-Barré syndrome or myasthenia gravis, and some traumatic or iatrogenic cases like surgery in this age group to correct congenital malformations, notably the cardiac or the esophageal surgery, or even prolonged intubation. So in general, in the pediatric causes for the vocal fold palsy differ from the adult causes in that the idiopathic group is much higher, almost 4 times those for the adults. There is this congenital causes for the vocal fold palsy, and there is the birth trauma and surgery to correct congenital anomalies, and also the infection group or neurological cases from Guillain-Barré syndrome or perinatal infection or myasthenia gravis, in contrast to the adults where the idiopathic group is much less. Iatrogenic group is the most frequent, and neurological and neoplastic causes comes after this. The presentation in the pediatric group is also different from those of adults. More than 50% of the cases would present in the first 12 hours after birth, and up to 85% of the cases will present with stridor. Of those 85%, almost 3/4 may require intubation initially. There are higher rates of spontaneous recovery, much higher than those of adults, particularly in the idiopathic groups and the birth trauma groups. But also, 50% of cases who present with vocal fold palsy in the pediatric group have concomitant anomalies. In some cases, this approaches 60% in the larynx. Things like laryngomalacia, subglottic stenosis, as well as functional swallowing disturbance. So a comprehensive evaluation must be carried out to rule out structural anomalies elsewhere, systemic or neurological problems elsewhere outside the larynx. Children and neonates or infants in particular present with the same classic triad of airway compromise, voice changes, or swallowing, the classic triad for vocal fold palsy, but in a particular order. The neonates and infants less than 6 months would almost invariably present with an inspiratory stridor. Sometimes it's even biphasic if there is a supraglottic contribution due to laryngomalacia. And this is the most common presenting feature, the stridor. Next comes the poor feeding. The baby would have sometimes cyanosis or during feeding, or sudden apneic episodes, or loose spells, or may fail to thrive due to the difficulty in the feeding. Those swallowing and feeding issues are particularly prominent if there is a high vagal paralysis and if there is bilateral rather than unilateral paralysis. And third would come the voice. There would be a weak cry. And those changes associated with bilateral palsy tend to manifest basically as a respiratory compromise. For children, sometimes there may be a delay in the diagnosis when the symptoms are subtle and unilateral. In older children, there may be voice changes that will present first before respiratory difficulties or feeding problems. There may also be a bit of cough or exercise intolerance. In unilateral paralysis, they may present with a soft or a breathy voice. There is also the risk of aspiration during swallowing, and this can be variable depending on whether the paralysis is unilateral or bilateral. Sometimes the presentation would be recurrent respiratory tract, lower respiratory tract infections and pneumonias resulting from silent aspiration. If the paralysis is bilateral, then the airway obstruction would be the leading presentation. Paradoxically, there may be reduced risk of aspiration and good voice, but the airway compromise would be the leading presentation. The severity of the symptoms, of course, would depend on factors like the vocal fold, the paralyzed vocal fold position, whether it is closer to the midline or a bit lateral, and any coexisting airway lesions that would happen in more than 50% of those children, including subglottic stenosis or laryngomalacia. In severe neglected cases, there may be growth retardation of children due to the chronic illness, sleep disorders associated with breathing difficulty, and there may be also neurodegenerative abnormalities. The main thing in taking the history of a patient with pediatric vocal fold palsy is to remember that this is not an isolated problem. In more than 50% of the cases, there may be associated other congenital malformations. The respiratory status, the feeding abilities, the weight, and the vaccination status should all be noted in the history. And the examination should be also thorough and include neurological and cardiovascular system examination. The flexible fiber-optic nasolaryngoscopy should be the starting method of examining the larynx, particularly as a bedside evaluation in a patient with a stable respiratory state, when the oxygen saturation is maintained and there are no cardiac anomalies. But if the child is crying, the view may be limited and formal evaluation under anesthesia may be necessary. The diagnostic workup would include three key factors: the flexible nasolaryngoscopy, which would show what is going on in the larynx, whether there is unilateral or bilateral paralysis, the glottic chink, the airway compromise, any pooling of saliva, any signs of aspiration, and so on. There's also the direct laryngoscopy, sometimes combined with suspension microlaryngoscopy, which would give even more detailed information about the airway and would allow palpation of the arytenoids for fixation or for misplacement, and allows for planning the management. And the third key diagnostic method would be imaging, either by a CT or an MRI, indicated when there is central or extrinsic compression causes of the larynx or the airway, or affecting the course of the recurrent laryngeal, the skull base or the mediastinum, or when things like a vascular ring is suspected, or when malformations, including brainstem malformations or anal chiari malformations, are suspected. In addition to these three key factors, things like EMGs can be useful in selected cases. It could help to distinguish between paralysis and arytenoid fixation or arytenoid displacement, for example. But the main importance for the EMG in the pediatric group is that it can strongly suggest that there is a very low chance of recovery if it has a high negative predictive value. So if it gives this indication that recovery is improbable, then definitive surgery can be considered. The other methods of diagnosis that can be used include things like video stroboscopy or video fluoroscopy for aspiration and swallowing dysfunction, when the age of the child permits this, to assess certain features of the voice or the swallowing acts. The method of choice in evaluation of pediatric vocal fold palsy is laryngoscopy and bronchoscopy with rigid telescopes under anesthesia. This will provide the opportunity to palpate the vocal folds and the arytenoids, differentiate between vocal fold palsy and other conditions like interarytenoid webs or posterior glottic stenosis or cricoid or arytenoid fixation. The vocal fold movements can be noted towards the end of the anesthesia as the child starts to wake up, and photographs, either still or videos, can be taken for further analysis. The prognosis is not bad. Spontaneous recovery is common, particularly in children who have neuropraxia of the recurrent laryngeal nerve after a birth trauma. It's therefore usual to observe the children with unilateral vocal fold palsy for periods extending up to 12 months before definitive surgery is undertaken. But for bilateral palsy, in whom the airway can be compromised, early intervention may have to be considered in the form of either a tracheostomy or temporary suture lateralization of the vocal folds, or even definitive airway surgery sometimes. But even then, the recent reviews of the decannulation rates after tracheostomies and suture lateralizations are encouraging in the area of 50 to 80% range of children have successful decannulation in due course. To summarize the clinical steps in the cases of pediatric vocal fold palsy, you start with stabilizing the airway and the feeding, particularly in neonates and particularly in bilateral vocal fold palsy. This is the initial step, followed by flexible laryngoscopy to confirm the diagnosis and assess the need for the management. Now, depending on the airway, whether it is compromised or not, this will be the next step. If it is compromised, then you would need to consider the options in terms of tracheostomy or suture lateralization, or even a definitive line of treatment like posterior cordotomy. We'll come to this in later part of this lecture. But if the airway is clear and there is no issues about an imminent obstruction, you can afford to observe the child and attend to the feeding difficulties. And if the child is old enough, he may actually benefit from some voice therapy. And you consider other investigations, including imaging or electromyography, to determine whether there is a chance for recovery or definitive surgery should be considered at this stage. The next thing is the laterality, because the management would depend on whether the vocal fold paralysis is unilateral or bilateral. In unilateral vocal fold palsy, you can afford to observe the patient for as long as necessary, sometimes up to 12 months. The options, if you are forced to intervene early because of aspiration, for example, or a very weak voice, is injection laryngoplasty, and sometimes you can even consider thyroplasty as temporary and reversible method. But if the two vocal folds are paralyzed, this will bring you to question number 2, whether the airway is compromised now or not, to consider the options for a reversible and temporary way of clearing the airway. What we have is the suture lateralization, the tracheostomy, and the posterior cordotomies. This should be the next step in your concentration. And follow-up will be dictated by the etiology, the chances of recovery, whether the patient would be tracheostomized or not. The usual time for monitoring would extend up to 12 months. And during this period, you can consider other treatment options like re-innervation in selected centers and selected cases. The decannulation rate for temporary tracheostomies are, as mentioned, quite high. But the real management principle is this: the very critical balance between keeping a clear airway with respiratory safety and preventing any aspiration and having swallowing protection, and a good voice. A clear airway would be dependent on a wider glottal chink. Swallowing protection against aspiration and voice outcomes would favor a narrower glottic chink and adducted vocal folds, and the critical balance would have to be decided on between the surgeon and the carers. And the management decisions should be taken one by one, depending on the cause, the laterality, the severity, the age of the child, and of course the parental preference. But it may start with a conservation period if there is no urgent need for a clear airway, and this should be basically observation for any signs of regeneration of the paralyzed vocal folds. During this period, you would need to support the feeding either by per oral or nasogastric tube for a short period, or even a gastrostomy if needed. And an early electromyography would be helpful in deciding whether there is any prospects of recovery or not. And it's good at telling if there is no prospects of recovery, and this is when a definitive surgery may be considered. The outcome for observation and conservative management in pediatric cases is quite good, because 42% of the idiopathic cases may recover spontaneously, Also, the decannulation rate after a tracheostomy is in excess of 50%. You can support the voice and swallowing in older children with some therapy. And medical treatment is usually measures to reduce reflux, whether dietary adjustment or some medications, and steroids may be indicated in some very selected cases. In cases of unilateral vocal fold palsy with a wide glottic chink, with difficulties with swallowing and aspiration and some voice problems in older children, the management would usually be injection medialization with temporary fillers, waiting for spontaneous recovery of the vocal folds. This is if the recovery is expected. If the recovery is not expected, then other definitive ways of treatment may be considered. If definitive surgery is required for unilateral vocal fold palsy with a wide glottic gap because recovery is improbable or because the symptoms have been persistent for more than a year, the usual thing is to consider medialization thyroplasty, usually needed in children a little bit elder children, like after 5 or 6 years of life. To this, you can add other things like arytenoid adduction procedures if needed. The operation is explained in a separate lecture, in a separate video. Now, in cases of bilateral vocal fold palsy, when the main problem is a compromised airway, if a temporary solution is required pending recovery of the vocal folds, the usual two methods to consider are either a temporary tracheostomy, considering that the decannulation rates are quite good, or the vocal fold suture lateralization technique, which is reversible. So these are the two ways to manage temporary and reversible bilateral vocal fold palsy. The suture lateralization by adjustable vocal fold latero-fixation is a reversible and a non-destructive technique that can be used in the immediate post-operative period after a thyroidectomy, for example, if bilateral vocal fold paralysis was noted. It entails passing of two trocars from the neck. Surface landmark of the vocal fold would be determined, and one trocar would be passed under the vocal fold and the other through the ventricle above the vocal fold. Through these trocars, you would pass a needle with an attached suture, which will be retrieved from one trocar and passed into the other. So that you would have the suture line around the posterior part of the glottis, and it would be tied in the neck. You can adjust it to effect a measured amount of lateralization of the vocal fold. It's a straightforward procedure and it's non-destructive. It's favored as in the children and when spontaneous recovery is expected, because you can always cut the suture line from outside if the vocal fold starts to move again. Aspiration initially is a small risk, but it soon gets better with patient taking voice and swallowing exercises. In cases of bilateral vocal fold palsy with a compromised airway, when definitive surgery is required because the chances of recovery are either negligible or because of a long observation period with no signs of recovery, the next management decision would be to trade off the widening of the posterior glottis against the price of weakening the voice and chances of aspiration. The options are a posterior cricoid split or endoscopic posterior cordotomy by laser, or a partial arytenoidectomy in very severe cases. Sometimes you may consider laryngeal re-innervation. There is an increasing interest in this procedure with better results being reported. and improved long-term functions. The evidence in children is growing, but it's still limited. This operation, microlaryngeal posterior cricoid split, can be used for airway compromise after denervation or after cricoarytenoid joint fixation. The posterior cricoid plate is splitted using laser, and then the space is created between the two cut ends by placing a cartilage graft inside. And this would widen this is the graft getting in place, and it would need to be secured between the two cut ends. This is a part of a rib graft, usually take about 1 centimeter or so. And once it is secured in its place, like a button in here, then it widens the posterior part of the glottis, and it can be useful in pediatric cases because it's a non-destructive technique. This is the graft being placed between the two cut ends of the cricoid plate and secured in place. And this has widened the posterior glottis significantly. This would clear the airway, but again, they're at a risk of some aspiration and some voice problems as well. The cordotomy is carried out with carbon dioxide laser in a super pulse or ultra pulse mode. You use the suction in order to retract the arytenoid away from the field, and then use the laser to cut transversely into the vocal fold, including the muscle fibers of the thyroarytenoides. And this cut would now be extended all the way to the inner perichondrium in type 3. It would stop at this level in type 1 together with the vocal process of the arytenoid. But here you can see it extended all the way up to the inner perichondrium, and then you also extended vertically a little bit like an L-shaped incision. And this is going to cause curling of the fibers of the thyroarytenoid muscle, forming the bulk of the vocal fold, and this will clear the airway. Here we are deepening the cordotomy through the muscle fibers, and you would see an extension, a obliquely vertical extension into this area as well, and this is going to help in the curling of the fibers. And part of the arytenoid would also be ablated together with its vocal process, and this would give a fairly satisfactory posterior airway just by doing it on one side. Of course, you can do it bilaterally, but then this would increase the risk of aspiration. The settings for the carbon dioxide laser in the super pulse or the ultra pulse mode would be power between 2 and 5 watts, and the power on would be about 0.2 to 0.4 seconds. And typically we do it only unilaterally first to see if this would be enough for the patient to have his tracheostomy tube removed, but if not, you can always do the other side as well. The risks and complications for the bilateral vocal fold palsy methods of treatment. Most techniques have comparable results in terms of decannulations and complications. Complications are usually the formation of laryngeal granulomas over raw surface in laser surgery, for example, or posterior glottic stenosis following the organization of these granulomas, or aspiration if you use the more radical procedures, particularly total arytenoidectomy. These are the 3 most common surgical complications. Revision surgery rates for all types of treatment for bilateral vocal fold palsy is quite high, approaching about 30%. 1 in 3 patients may require another procedure. The pediatric cases usually have a high spontaneous recovery rate, particularly in the idiopathic and the birth trauma cases. About 2/3 of them may recover spontaneously, so it's worth waiting for a year before considering intervention, surgical intervention. Patients who were dependent on tracheostomy can get decannulation in a range of between 50-something and 70-something% of the cases. More than 20% of the cases would require some form of intervention in order to have successful decannulation, and this is usually either a suture, lateralization, or endoscopic cricoid split. The voice and swallowing outcomes are variable. The more you clear the airway, the more risk of aspiration or a weaker, breathier voice. The more radical and surgical intervention would increase that risk substantially. The future direction would be with the emerging therapies, including laryngeal pacing, with gene therapy, or selective re-innervation, but that would need time before it is established. This table summarizes the outcome of 4 different procedures to secure an airway in cases of bilateral vocal fold palsy with a compromised airway requiring definitive treatment. The outcome is quite good with the 4 procedures, very much comparable. The suture lateralization procedure has the advantage of being temporary and non-destructive and reversible, and it's the usual starting point if tracheostomy is to be avoided. The posterior cordotomy have a very high success rate as well, with very high decannulation, and it's used for persistent obstruction resistant to any other alternatives. If this fails, then the next thing to consider would be a partial arytenoidectomy, but considering the risks of aspiration, and it is a destructive operation, it is reserved only for failed conservative methods or endoscopic posterior cordotomy. Cricoid split graft is giving promising results, and this is particularly useful in patients who have congenital airway stenosis or fixation of the arytenoids. And finally, this is a table of a summary of evidence from some key studies, recent key studies, a systematic review in the last year on various ways of treating bilateral vocal fold paralysis in pediatric cases with different techniques, showing a high decannulation rate by suture Latero-fixation or arytenoidectomy or posterior cordotomy, a bit lower for re-innervation, but that is a more promising technique of treating this condition. The other systematic review, also from last year, was also comparing decannulation rates for different procedures and showed that the successful decannulation of tracheostomies could be achieved in 70 to 80% of the cases. Another case series in 2023 for endoscopic percutaneous suture lateralization showed that the tracheostomy could be avoided in as much as 80% or so of the cases. Similar results in this year on the same problem, and the same technique of suture lateralization again showed that in about 80% of the cases tracheostomy can be avoided by suture lateralization. The other series in 2019 was for injection laryngoplasty and showed that it improved swallowing and voice and have a very low adverse events. The last 2 studies were about electromyography and showed confirmed the suspicion that it is actually quite useful to indicate that the chances of recovery are slim, with a high negative predictive value for non-recovery. By this, we come to the end of this presentation on the pediatric vocal fold palsy. Assalamu alaikum.